Good afternoon, and welcome to this special edition of our weekly McGill Alumni webcast series, COVID-19 and the World's Vulnerable Communities, a joint presentation between McGill's Office of University Advancement and its School of Population and Global Health. My name is Derek Kassoff, Managing Director of Communications at the Office of University Advancement, and I'm pleased to be co-hosting this webcast with Dr. Timothy Evans, Inaugural Director of the School of Population and Global Health, formerly the Assistant Director General at the World Health Organization, and a familiar face to those of you who tune into these webcasts regularly. Much has been made of the terrible human toll that this coronavirus pandemic has taken, first in Asia and more recently in Western Europe and North America, as our relatively strong healthcare systems and economic institutions manage their best to cope with the rising spread of infections and hospitalizations and the soaring number of shuttered businesses and unemployed citizens. But what could nations and populations in the rest of the world be facing? In Latin America, in Africa, and in less developed parts of Asia, as the COVID-19 virus continues its lethal march across the planet? Are these countries prepared to protect their populations and care for the infected? Are frontline healthcare workers equipped to deal with the crisis? And what might a constructive global response look like? It's Thursday, April 30th. And today, Dr. Evans and I are joined by some of the world's leading experts in global health, men and women who have developed policies and fought on the front lines in many of the world's hotspots, and who are now all mobilized in the global fight to curb the spread of COVID-19. Let me quickly introduce them. We have Dr. Agnes Binagwaho, who is joining us today from Kigali, Rwanda, where she is Vice Chancellor at the University of Global Health Equity and Senior Advisor to the World Health Organization's Director General. She also served as Rwanda's Minister of Health from 2011 to 2016. Welcome, Dr. Binagwaho. We have with us Dr. Ariel Pablo Mendez, originally from Mexico. He is a professor of medicine at the Columbia University Medical Center. In 2011, President Barack Obama appointed him to lead USAID's Bureau for Global Health. Welcome. Patricio Marquez is from Ecuador. He serves as a senior consultant for the World Bank Group's Global Emergency Response to COVID-19. He's a senior associate at the Johns Hopkins University Bloomberg School of Public Health and a member of the External Advisory Group for the Global Mental Health Program at the University of Washington. Welcome. Dr. Raj Panjabi is a Liberian Indian American physician, born in Liberia, educated in the United States. He is the CEO of Last Mile Health, a nonprofit organization he co-founded that works to save lives in some of the world's most remote communities. In his spare time, he's also an assistant professor of medicine at Harvard Medical School and the Division of Global Health Equity at Brigham and Women's Hospital. Welcome. And finally, Dr. Joanne Liu, born in Quebec City, a two-time McGill University graduate, the former international president of Médecins Sans Frontières, Doctors Without Borders, and now an associate professor of medicine at the University of Montreal and professor of clinical medicine here at McGill. Welcome to all of you, and thank you, Dr. Evans, for recruiting such a star-studded panel of experts for us. Before we delve into the discussion of how this pandemic is playing out on the global scale, I would like to first ask Dr. Evans about a very significant development that recently took place right here in Canada. A week ago today, Prime Minister Justin Trudeau announced the establishment of Canada's COVID-19 Immunity Task Force, which will oversee the coordination of countrywide blood testing to tell us how widely the virus is spread in Canada and provide reliable estimates of potential immunity and vulnerabilities in the Canadian population. The task force will be co-chaired by McGill professor Dr. Catherine Hankins and will include a secretariat that is to be led by you, Dr. Evans. So first of all, congratulations on this appointment. And can you tell us a little bit more about what this initiative is all about and why it is such an important element in Canada's response to the pandemic?
Yeah, well, thank you very much, Derek, and thanks to all our panelists for sparing time to join us today. Really, really much appreciated. Let me very briefly outline what the Prime Minister announced last week as the COVID Immunity Task Force. And what it represents is an opportunity to bring another critical piece of evidence to understand the bigger picture of the epidemic and pandemic as it's affecting Canadians. And this is really a complement to the current testing, but it's going to give us a much bigger picture. The current testing gives us some sense of the tip of the iceberg, what the number of affected cases are, and the testing is very much oriented to those people who present with symptoms. And what we're missing are those people who are asymptomatic and who we know are infected, as a number of studies have suggested. So what we really hope to with these immunity tests is get a sense of how big the base of the iceberg is, the total population that's been exposed, and shows some form of immunity in response to that exposure. That will give us a much better sense of where we were when this epidemic started by looking back at blood bank samples from January and February and seeing if we have evidence of immunity in the samples that were provided back then. It gives us a sense of where we are now as we reach the peak in this first wave of the infection. And it's going to be very instrumental in understanding how we manage the epidemic moving forward in terms of a second wave. If we find that there's a large percentage of the population that has some evidence of immunity based on these tests, then that is a very different scenario than if it's a much narrower part of the population that has evidence of immunity. And so I think this will be helpful for us to understand as one critical part of information as to how we manage opening up of our economy, both safely in terms of public health and with respect to sustaining key frontline facing health workers that we know are indispensable, like healthcare workers, as well as policemen, firefighters, and others that are critical to keeping things moving. So the task force over 2 years would like to really generate that information to help manage on a full front across Canada an understanding of this infection and the evolving immunity pattern.
Mm-hmm. And do we know how accurate these antibody tests are? I mean, is there any assurance that people that have the antibodies and have presumably been infected cannot be reinfected again?
We're getting more and more evidence on that, and I think there's reasons to be very critical about understanding the performance of the tests and the way in which those we're evaluating the tests. I think is evolving and improving, and I think we're finding much better tests that will meet minimum criteria of accuracy. We're working very closely in Canada with the National Microbiology Laboratory, and they will set that standard, which will make sure all tests meet in order to get the most accurate tests in the population.
Great. Well, wonderful and encouraging news, and so nice to see that McGill University here in Canada is playing such a lead role in moving all of this forward. So thank you for that update. So I'd like to turn our attention beyond Canada's borders now. And before I turn it back to you, Dr. Evans, to jump in and sort of lead the next part of the conversation, I thought it might be interesting just to turn to each of our panelists. I know you all have a lot to say over the next hour and a half that we have together. But if I could ask you in maybe a short, perhaps 90-second summary, to maybe just speak to what you are thinking is the biggest global health concern you have right now with regards to the COVID-19 pandemic, based on your experience and your vantage point right now. Maybe I'll start with you, Dr. Binagwaho in Rwanda. Can you tell us quickly what are your biggest concerns right now?
My bigger concern with the COVID is that many people believe that this virus is an equalizer, and that's not true. Vulnerable populations are far more affected than the people who are not vulnerable, and this across the world. You can see Latinos and Black communities in America, but all over Africa, the poorest are the one who cannot respect social distancing, who doesn't have enough reserve to have food every day. So they need support of their government and their communities to bring food on the table every day. And this is my bigger concern, because the high rate of infection among the vulnerable communities and the world that is not moving to solve that.
Mm-hmm. Okay, and I'm sure we'll have a chance to delve into a lot of those issues during our time here. Dr. Pablo Mendez, how about yourself? What are your biggest worries right now? You have to just unmute yourself, please.
Thank you. There are many concerns, but for low middle income countries in the global health space, a lack of preparation. We have learned painfully that lack of preparation here in the United States in February or a month ago in Russia, you don't believe it's going to be that bad in your country. It's just, you don't believe it. But then you get this exponential hit, and then panic ensues. And so preparation, there's an advantage to many countries in Latin America, Africa, and so on, that where the global travel patterns delay the arrival of the virus. So that's an advantage that has to be made use of. I think we need to do three important things in that sense. One is educate people. This is coming, it's going to be big. Be ready for mass testing, and I'm glad Canada is now also trying to assert themselves in understanding the full iceberg of the epidemic, and have national trusted expertise to guide the response. I think the hospitals must be prepared, and we know of this, but the spike is so acute, and I work now in New York at a Presbyterian hospital, and even as you prepare, the spike will pierce through your preparations in the ICU, because even if it ends up being twice or three times the number of flu deaths, if you compress a season of flu from 9 months into 1 month times 2 or 3, it really overwhelms hospitals. So being prepared for that. And then third, we have to really make sure that we understand by now very clearly that this is an age bifurcated epidemic. Over 95% of the deaths are in the elderly and people who are sick. So isolating the elderly can help diminish the fatalities, but without stopping the economy, because then you get into a lot of other headaches. And at least we're watching the approach of Sweden, and let's see if we can learn from that as well as from the lockdowns elsewhere.
Great, thank you for that insight. Mr. Marquez, how about you?
Yes, first of all, Derek, let me begin by thanking you, Morgan, and the team at McGill for organizing this event. Many thanks. And also allow me to salute my fellow panelists, and in particular, I would like to extend my sincere appreciation for the kind invitation offered by my former boss at the World Bank, Dr. Tim Evans. It's nice to see you again, Tim. So, in relation to this, to the question that has been posed, I think that I would like to echo what Agnes said. I think that my main concern right now is that COVID-19 will only aggravate the significant income gaps, the significant inequalities that we are observing in the world nowadays, not only across countries, but within countries. And I think that is something that we have to be mindful of. We already, as Agnes said, in the United States, 65% of those who are losing their lives are African Americans, are Latino populations. So those tend to be usually at the bottom of the income scale. In Latin America, the most unequal region in the world, the situation is going to be further aggravated, particularly affecting the indigenous populations. The other thing that perhaps comes out of this realization is that moving forward, the war that we had up to the beginning of this year is going to wither away. We are going to have to create a new normal, and the new normal will have to imply rethinking about the development models that we have been following thus far. It has to imply a rethinking on how we collaborate across countries, how solidarity becomes a critical element of that collaboration among countries. And I think that we also need to think how to prioritize investments and programs. I think that investing in basic public health and essential medical care for all is no longer a choice. It has to be a priority policy decision across countries. Thanks.
Great. Thank you very much for those words. Dr. Panjabi, how about yourself?
Well, thank you. And it's good to, I feel like the last time Patricia, Ariel, Tim, Joanne, and Dr. Agnes and I were all working together was around the Ebola epidemic in West Africa. And, I think those are different viruses, different epidemiological patterns, but there's some similar issues coming up in this one that make me concerned. Number one, we are unfocused in the hotspots. We understand that testing, isolation, tracing, quarantine, those are the four sides of the box to box in the virus, to create viral suppression. But we don't have sufficient focus on a data-driven approach to target setting, that every actor in this effort is focusing on testing at the level needed, on tracing 100% of the contacts, on ensuring that within hours, those who are tested positive are isolated or sent for treatment. That data-driven approach is missing, and that's why I say we're unfocused in the hotspots. But second, what I'm concerned about, especially in low and middle income countries, as my colleague Ariel just said, is that we're blind. We have some big blind spots, specifically around primary healthcare. There was a study supported in part by Global Affairs Canada that some on the line may know about. The World Bank, Patricio and Tim's old employers put out last week that said, in addition to the pandemic itself, the pandemic is causing a collapse in primary healthcare systems. We saw during the Ebola epidemic that there was a 140% increase in untreated malaria cases. There was a 75% increase in maternal mortality. We already have projections from that Global Affairs Canada supported study at Hopkins that shows there could be as many as increase as much as 45% increase in child mortality and a 40% increase in maternal mortality, because health systems have collapsed because people are stopped going to those health systems, or the health workers are unprotected and not equipped to keep primary healthcare services going. So that's the second challenge. And I think the third is related to those workers. We still are seeing that community and frontline health workers, the nurses, the physician assistants, those village health workers or city health workers that are proximal to the communities, are not getting the protection they need. Many of the community health workers, for instance, in the world, who are critical on the one point for getting the focus on hotspots and dealing with those blind spots, simply don't have the masks, the gloves, the face shields that they need. And especially in poor settings. And that's partly because there is a massive amount of competition for the supplies that are on the market, largely going to the global north, where of course there are shortages as well, but that is pricing out and competing out poorer countries for getting those supplies for their workers. So those are my three concerns, Derek.
Right, there's a lot there that hopefully we'll have a chance to unpack as well today. And finally, Dr. Liu, how about yourself? What are your sort of concerns and perspective on this pandemic?
Good morning and good afternoon to everybody. Well, I guess it's hard, to come last, when everybody has said some very, very, I would say, outstanding concern. I think that for me, at macro level, my biggest concern is how will our solidarity mechanisms will play out at global level, knowing that right now it's been a competition because of shortage of resources. And then I think that we have been doing a lot of simulation scenario in different events at Davos or in different places. But I think we never run the scenario that there's going to be a pandemic and everybody around the world will run the same PPE, the same N95, and so how are we going to play that? And so my biggest concern at macro level is that solidarity will be the collateral damage of COVID-19 pandemic. That's for it. At micro level, I think that my biggest level has been echoed by different panelists is how are we gonna make sure that trap sub-community will not be the default price to pay. This is what we're doing right now in Northern Europe and in States and Canada. And our trap community has been the elder homes, the elder people. But there's other, trap community that cannot move, that are vulnerable and have no choices. And it's people in detention centers, it's people in refugee camp or IDP camps. And we don't have really a real solution for them, except that looking into what we call radical shielding, meaning that we are stopping communication. But we have to do better than what we've done in Canada, is doing radical shielding, but not making sure they were having access to care. So how are we going to shield those populations? That's what I call as well the reverse isolation. We don't only isolate the sick, but we isolate the vulnerable. But we are making sure they still have access to care. So these are my biggest concern. Thank you.
Great. Well, thank you for that insight. So let me turn it over to Dr. Evans now for this next part of our discussion. And I know you've prepared a few questions that you want to put out to your fellow global health experts. So I'll turn it over to you to sort of begin that portion here.
Thanks, Derek, and thanks to all the panelists for those superb introductory remarks, which I think give us all not only a lot of food for thought, but a really nice spectrum of the issues. Let me go back to Dr. Binagwaho, and can you give us some understanding of what are things like on the ground right now in Rwanda? And then speak from your vantage point as the Vice Chancellor of the University for Global Health Equity. How are you managing your university that's focused on health equity in terms of its leadership with respect to this crisis?
Thank you. This is our day-to-day life, and I'm lucky to be in Rwanda now. Rwanda is a special country because we have 5 big borders with RDC, with Uganda, with Tanzania, and with Burundi, and also the international border at the airport. But we took the pandemic seriously when China rang the bell for the world. That means mid-January. So mid-January, we decided as a country to take the temperature from each and everyone coming in the country, whatever place they come from, and to stop our regular flight to China. At that time, nobody has, we start among the first because we knew that those are measures we need to do to protect our population. So we took the temperature at that time and we test people with fever and we isolate them as it was advised by the WHO and experienced by China and other countries in Asia. We had our first case in March 14. But we were ready, meaning the media, the churches, all the schools, all the institutions, all the constituency in Rwanda were ready and knew what each and every one has to do. We had the first case in the evening of the 14th, before midnight, the lockdown of the country was announced. No more schools, no more churches, mosque, all the religion. All the office will be given through radio and TV, and all the head of all churches has agreed because they had prepared that with the government. And nobody was allowed to go out except for vital issues. And 6 days after, people had, the Rwandan outside Rwanda had time to come back home. And after that, all the planes stopped except cargo for vital goods. As I told you, we are quite special because all the goods that enter in Rwanda have to transit 2 or 3 countries. And so the 21st, all the flights, no more flight around the country, all the borders closed. Rwanda can come in, anyone can come in, but with 15 days isolation, with or without symptom, and a negative test to go outside. And all those measures are still ongoing, and we put a mask when we have to go outside for shopping, etc. And if we go outside without a reason, you have a fine. And if you persist, you go to jail. So that means there is an enforcement of those measures. But because the vulnerable have not enough food or reserve, the government also has put in place a distribution system for the poor. We are divided in village, like here around my house, we are a village. We know 2 families that are very poor. We give by solidarity a portion of what we have for them to survive. And the whole head of village that we elected are in charge of make it happen across the country. And the local government are in charge to support and facilitate that. The government give budget for that as well. As all the schools are closed, we have many foreigners in among our staff and our students. So we ask the permission not to close, but to respect all the measures. Social distancing, all the students have their own rooms, only e-learning, even if the teachers and the students are in the same campus, and a physical exam every week, and a mental health also assessment to make sure that everybody survive the lockdown properly. Nobody comes in or out the campus, but before taking that measure, the 15, all the staff and all the students were asked, do you want to stay or to join your family? All the students stayed. We communicate with the parents, all the parents agreed. So now we are in the middle of our 5th week of lockdown. Nobody has entered or get out of the campus. Same for the country. And we have 2012 cases. We have 225 cases of COVID since the beginning. 98 have already recovered, and we have 127 active cases. But among those active cases, 71 came the last week from our brothers from Tanzania. You know, Tanzania has done nothing. No lockdown, no mask, no protection. Everything is open. And our goods are coming from Dar es Salaam or Zanzibar by truck. And the majority of those 71 are truck drivers coming back from Tanzania. So now we have created an open health center at the border. All the trucks have to discharge their goods at the border. A truck from Rwanda is coming. There is disinfection, and people with PPP are handling the goods. But that means we are flexible, we adapt. It's not a done deal. We are going to face unexpected problem that we don't know yet. But for the time being, the Rwandan population is safe, and the infection inside Rwanda is going down. Anyone coming in Rwanda, like all those truck drivers, has received the care as Rwandan, and we have 0 deaths since the beginning. We also do mass testing and random testing in the population to follow.
Fantastic. Well, Agnes, it's wonderful, and it's really so enlightening to have that in-depth experience relayed by you, and also so interesting to understand the interdependence of your response with respect to your neighboring countries and how you're managing that. So thank you. I'm going to move on to Dr. Marquez, who actually misrepresented things. I worked for Patricio when I was at the World Bank, not the other way around. And I would like, Patricio, if you could give us some sense of how the World Bank is really is stepping up to support countries at the moment, and whether you think the bank is really the leading edge of that new solidarity that you say is so important for the world at this time.
Yes. Okay, thanks, Tim. Let me begin with a disclaimer. I had retired from the World Bank in August, at the beginning of August 2019, just before Tim left, after serving 32 years in the institution. And I was invited to come back by the current director, Dr. Mohamed Pateh, to help support the preparation of the global response to COVID-19. Therefore, I'm going to speak on a personal capacity and not as a World Bank staff member. I'm just a consultant nowadays, although my history is tied to the World Bank with a lot of pride. Well, I think that the first point that I would like to mention is that we have continued to learn from previous experiences. I think during the 2014-2015 Ebola response in West Africa, we were able to move relatively fast under the leadership of Tim and Dr. Jim Kim. And we were able to put together a program to help the 3 countries in West Africa in a relatively short period of time, 3 weeks. So we had that standard in mind, and right after the board of directors of the World Bank approved the establishment of an emergency facility to support countries across the world to deal with the impact and the consequences of the virus. We went to work in putting together a global framework for supporting activities in the health sector. The global framework that was put together has a total cost of $6 billion and serves as a menu of options that are grouped in 5 components. So countries that that access that program can choose from that many options in accordance to their needs and the stage of the epidemic. The program we prepared again, well, actually we beat our Ebola record. We put together the program in 2.5 weeks. The program was approved by the board of directors at the beginning on April the 2nd, and along with the first 25 projects. So at this moment, at the end of April, 57 countries across the world have a COVID-19 project that is supported under this program with a total commitment of $3.3 billion. And an additional 17 projects are currently under preparation, including projects in Brazil and hopefully one in China to deal with One Health issues, particularly on the interface of the veterinary and the public health systems. But as I said before, one has to see this crisis not only as a public health crisis, but rather as a broad social and an economic crisis that's challenging us to respond across sectors. So the platform has to be a multi-sectoral platform. So under phase 1 of the bank's response, the emphasis has been in supporting countries in addressing the public health dimension of this crisis. And currently, phase 2 is under preparation, and we expect that the World Bank will allocate about $160 billion as announced by President Malpass during the G20 meeting in order to support countries in beefing up their social assistance programs, particularly cash transfers, the support for the purchase of goods to keep open the food commodities markets and trade lines, and also to reactivate the economic production and protect workers from the course of unemployment and lack of benefits, particularly health insurance benefits that come with a job in the formal sector.
Great,
So
great.
these two dimensions are coming are going to be implemented in tandem in order to address the multidimensional aspects of the crisis.
Great.
Thanks.
Well, thank you, Patricio, and it's great that you were able to lend your 3 decades of wisdom to this 2-phase approach, which sounds very promising. I'm going to switch now to Dr. Punjabi, and Raj, you gave us a triple whammy: no data, public health, primary healthcare collapse, and no support for frontline workers. As your opening salvo, as what's the challenges. Tell us, you're the CEO of Last Mile Health. How are you mobilizing community health workers in the front lines of health systems to address the data, they sustain primary care, and really, very importantly, protect frontline workers?
Thanks, Dr. Evans. Let me start by just sharing a quick example from, just a few weeks ago. I was in Liberia with our community health teams, which are largely community health workers, but also nurses supporting them, from frontline nurses supporting them from clinics. And I was with a young woman named Mardia Sino. Mardia, like many community health workers, had been hired from her own community. She had actually had to drop out of school because her parents couldn't afford to send her over to high school. She has been working in her village. It's in the rainforest in an area called River Sus. In fact, had first started doing this work because she and her colleagues, because MSF, when Joanne was leading, when Dr. Liu was leading MSF, had been working with the help of USAID and the banks, the same program Patricio just mentioned, to respond to Ebola. There was an outbreak in the forest, and there needed to be a workforce that doctors and nurses needed, that came from the community themselves. So Mardia and others signed up to do the testing, to help with the test collections, the sample collections, to do the tracing of those who were exposed to the virus, to track the contacts, to help with supporting patients who were isolated with social support, and helping refer others to treatment. Those 4 sides of the box needed to suppress the virus. But a few weeks ago, before COVID became explosive in Liberia, she was treating children for malaria, helping organize vaccine outreach, making sure that mothers who needed prenatal care got it at the clinic. And that investment that was made by the World Bank, USAID, the Liberian government, and several others in hiring her, training her, equipping her, is now paying returns, because Liberia has been able to quickly mobilize Mardia and about 4,000 colleagues like her across the entire country to do the testing, to help with sample transport for nurses, to help with educating the community, to find those who are sick and get them into care, to ensure that those who are isolated get the social support they need, and those who fall sick are also referred upstream. So again, that 4 sides of the box, the testing, the tracing, the treatment, and the isolation, is the way that Mardia is helping on the one hand. But the second area of help is, of course, to deal with the blind spots that I spoke about earlier. We're neglecting those blind spots. If we know already that there could be a 40% increase in child and maternal mortality because health systems collapse, health workers stop coming to work, patients get worried about going to the care system. That's what we saw during Ebola. Then we've got to bring care closer to those patients, and we've got to make sure that community health workers are equipped. So our teams just work with the Liberian government, now working with the Malawian government, and somewhat with Ethiopia. But in Liberia, what has happened is that Ministry of Health has put together a 100-page training curriculum that is allowing, that is enabling and empowering workers like Mardia to provide adjusted protocols for primary healthcare, meaning don't stop malaria treatment, perhaps modify the protocol where you might empirically treat without a test based on data locally. You might treat your patients with diarrhea. You might ensure that contraceptives are no longer injectable, but perhaps oral. Maintain the distance that's needed from your patient. Don the PPE that's needed to keep care going. That's what Mardia and the thousands of workers in Liberia are being trained to do. And that's going to be vital if we're going to have any shot at paying attention to those blind spots where the health system's collapsing. If we have any shot at keeping malaria going and sustaining primary health care. So those are the two areas, Dr. Evans, that Liberia is focusing on, and we're seeing other countries take on. Let me just emphasize the other point I made is that we just can't get there without ensuring the Mardias of the world have the gloves, the masks, the face shields, and let me say the pay and support they need to go forward. We're just not seeing sufficient amounts of this. There's, of course, an interest in making sure the ICU doctors and physicians, like myself and others, have the equipment. That needs to be there. But we also should be capable of quantifying the PPE needs for those community health workers themselves. We're not seeing it. We've seen in India, for instance, nearly 1 million ASHA workers go out to do this kind of work that Mardia is doing. These are community-based health workers. And there are several media reports in just the last few weeks where many of those workers don't even have a mask provided to them. Not only will that be bad for dealing with the blind spots and the hot spots, but you can cause more harm than good if you don't safely protect these workers, because they could become super spreaders in their own community of the virus itself. So we've got to have PPE for all health workers, including frontline and community health workers.
Great. Well, thanks, Dr. Punjabi. And hopefully the World Bank's support to countries can make sure that PPE is part of the package, as well as others that are mobilizing. I'd like to change to shift now to Dr. Dew and to draw on Dr. Punjabi's metaphors. Your career could be characterized as having worked in so many hotspots and pointing out systematic blind spots, especially with respect to vulnerable populations. So it'd be great just to get your reflections then on what lessons can we draw from that previous experience, and how can we direct those to the communities that you mentioned in your first comments that are particularly vulnerable in terms of the consequences, risks to and consequences of the current pandemic?
Oh, thank you very much. I think that I just, about, what can we draw from previous experience? Somehow I've developed a bit of a passion for pandemic, because I think it's such a humbling exercise. Somehow, when an epidemic becomes a pandemic and just sweep across a country, it has no mercy. It's going to wreck everything that is weak. Every little weak point is going to just fall apart. And it would put it right under the spotlight. So that's for anyone who wants to be like a learning person. That's a good humility exercise, and you can improve. So few things at macro level. It's been alluded in different ways, by the different panelists. But at macro level, for me, the lesson learned is we talk about our solidarity, but even if we don't want to be in solidarity, because of our interconnectedness, it's pay off much more to be in solidarity with each other at nation level, at individual level, that is the thing. And we've learned that because we're so interconnected. So we cannot pretend like us in Canada today that the way things are handled in the US doesn't affect us. It does affect us because we will not keep, our border closed forever. So how are we going to manage that? It's we only healthy as much as you are healthy. So it's to make everybody healthier, it depends on making each of us healthier. I think the other thing that we learn is, and then we put it in place, we tend to forget, but let's say some bright stuff about what happened, is we weren't slipping on the switch this time. We declared the public health emergency of international concern fairly quick. And then the signal was given, hey guys, wake up, something is happening. And then we tell the world. But the thing is, after that is, how did we adapt? And the thing is, as much as some of the IC country, the high income country, thinks they're so smart about themselves, the reality, they try to fit their really inflated bureaucratic decision making to an emergency. And actually, we're actually not very good at it. We're failing. We need fast track decision making platform if we want to tackle that in real time. But the other thing that we learned, that just to keep something on the bright side, is we've created some common good, and anyway, some concept of common good. And the concept on data sharing, on research, on what was going to come for the clinical trials in terms of developing vaccine or therapeutic solution or rapid diagnostic test. And somehow, we've learned that this needs to happen while we are tackling a pandemic. And we're a bit better in terms of open, I would say, open data platform, open research platform. So I think that we should not forget that, and it's a big improvement since last time. And to rephrase things, from Dr. Benjamin a different way, my motto is about the blind spots and the primary healthcare collapse is, during a pandemic, when we're so focused on addressing right now COVID-19, then we should make sure that no one should die of a treatable and preventable diseases. And in right now, in some countries, and in my country, in Canada, we have put on pause our healthcare system for weeks now. And we probably will have a lot of patients who will not have access to care or decided to not access it. And so that's something to remember. At micro level, I think there's 5 things I want to bring up. It's the community role. I think we said it over and over again. Epidemic starts and stops at the community. If the community is not involved, it will not happen. The Liberia, I would say what I call miracle in October 2014 is when the community really owned the epidemic and just said, we're going to change our behavior because we know that it's going to change the course of events. And this is what happened as well in Canada. We asked the community, hey, lock down, guys, because you're going to help us to flatten the curve. And this way, we won't overwhelm our healthcare system. So community is key. The other thing is at personal level is I think that we have overlooked the human factor, the fear factor. And it's there, it's everywhere. And we have to acknowledge it, and we have to understand why and how it plays on people, on general people, but on healthcare worker. And the fact that when we tell them, we are managing a shortage, and as many of you saying about the PPE, we cannot send people at the front line without being protected. Our last line of defense is our frontline worker. And if we don't protect them, and if we keep telling them, use wisely your PPE, use wisely your mask, how can you use wisely a mask? I just need a mask. I just need the shield if you want me to go and care for a patient. So the biosafety of everybody that works at the front line is key. Otherwise, healthcare worker or healthcare entity or facilities will become amplification of the COVID-19. And last but not least, because we often overlook that, is what we've learned in Ebola is like the human being is not meant to die alone. And then that's what we do now in our hospital, in our elder homes. People are dying alone. And they're dying with people dressed in PPE, looking like cosmonaut. This is not meant to happen. And we need to do our utmost to change that. And there's no reason that the family member cannot learn to put PPE and then spend the last 15 minutes with someone who's jumping over the fence. I guess that's it for me.
Well, thanks, Joanne, for those macro and micro comments. Very, very salient. And as somebody who's in the administration of the university, we're looking at conferring an economics degree on you, given you've got both macro and micro well in hand. With that, let me shift to Dr. Pavlos. And Ariel, you led the biggest aid agency in the world in its health programs under the Obama administration. And ministers of finance are now coping with the biggest fiscal deficits they've had to consider in decades. Is there a role and a room in the current development assistance agenda for growing development assistance or repurposing it to have perhaps greater return on investment? What are your thoughts on those fronts?
Well, thanks, Tim. And clearly, the world of global health has changed. And a decade or two ago, a world in which rich countries help poor countries, in which donors set agendas, has changed for many reasons, not only because what used to be called developing countries have grown in so many good ways, despite some exceptions, but also because their economies have also continued to grow in many of them, as opposed to many of the donor countries' economies that in the last decade, after the financial markets collapsed, have really not been growing much, and that has meant that the growth of development assistance for health that we saw in the first decade of the century has sort of flattened, and that is significant. But it's more significant, really, all the qualitative issues. Nonetheless, of course, development assistance for health still is important, especially for many of the poorest countries. And USAID has committed just now close to $1 billion for COVID. Some of that is new money that the Congress is moving, but also is repurposing of money, as we did also when we had Ebola and Zika. And I think the agency's role, although different now, because clearly, and as Dr. Binagwaho exemplifies very well, I mean, the ministers of health are in charge, and increasingly governments are in charge. And the role of civil society, the role of donors has changed. But in the poorest countries, these agencies still play a very important role. Those resources can be still significant, but perhaps more because of the nature of the work. One is they are multi-sectoral agencies. USAID has multiple sectors involved, and responses to things like Ebola or COVID demands not only public health and emergency response, but also addressing social mobilization, the economics, and so on, as you point out. And USAID's new partnership initiative is trying to leverage all of those sectors to help countries fight COVID. Second, many of these agencies, like the bank and so on, are grounded in countries supporting governments and communities, and that's an important thing, but also have regional umbrellas. And COVID is a hyperacute epidemic. It really hits you over 2 or 3 months and winds down for a while and moves to the next hotspot. And so having regional approaches will be very important to make sure that, as we're doing here, here in New York, as you know, we didn't get to utilize all of the ventilators that we got because as the spike was growing. So we can now lend those ventilators to New Jersey. So similar things will have to occur in sub-Saharan Africa, and to plan for that ahead will be important. So agencies that have supranational regional structures can help do that expediently. And third, bilateral agencies also support global efforts and systems issues, from measurements to healthcare workers and so on. But at the global level, play an important role in supporting normative role and emergency response. And so, of course, we are all disappointed that the United States has announced to lock the support for WHO in the midst of a pandemic. It's shameful. And we are hoping that which today is for 60 days, and so will be lifted. And so I hope that we all make pressure to support WHO and to make sure that the Trump administration reverse that decision.
Well, thank you, Ariel, and I just want to thank everybody. I think knowing the five of you as well as I do, you're all united in your sense of one world health and universal health coverage. And I think what I'm hearing from you is that if there ever was a time for universal health coverage, not only within countries, but across, this is perhaps the moment to really seize on, to see how we can really embrace that and provide the security and the safety, but I think very importantly, the dignity that every citizen deserves with respect to their health. Derek, I'm going to pass over to you because I know you have some questions, but I just wanted to thank again our panelists for those fantastic remarks.
Okay, great. I think Mr. Marquez wants to jump in.
Yes.
He wants to add to that last piece. Go ahead.
Yes, perhaps, I would like to complement what Ariel mentioned as his last point. I think that perhaps we are already starting to witness the importance of a regional institution, the importance of a regional institution that can be ready in order to support countries. And I'm referring specifically to the Africa CDC. The Africa CDC that was established right after the Ebola outbreak in 2014 now is a reality. You have sub-regional centers across Africa. And I think that the promise that we thought that could be delivered using these regional institutions is now a reality. So congratulations and let's salute to the our African counterparts. And the bank is already committed and is supporting with a program worth $350 million in order to accelerate the activities under the Africa CDC.
Mm-hmm. Great, thank you. Dr. Binagwaho, yes, go ahead.
Yeah, I want to put a bemol on what you just say, my friend, because we have 6 centers for how many countries? And the problem are at country level now, meaning how the countries are managing the pandemic. So it's good to have that. We need, because I remember the time when we had to send sample in Atlanta to have a confirmation. It's no longer the case. But make the COVID preparedness is beyond that, and it's local. If we manage to have hospitals prepared to receive the case, and so that all health centers continue to deliver women, to treat malaria, to treat ordinary pneumonia, then the population is safe. So we need everything.
Great. Thank you. So listen, we have about 30 minutes left, and I appreciate the fact that you're willing to stay on, all of you, a little bit longer with us today. I want to sort of circle back to some of the opening remarks that you made, Dr. Binagwaho. Maybe I'll sort of address this to you. It was glad to hear that things are in such great shape in Rwanda, but clearly that's not the case in many low-income countries around the world that we hear about. In fact, just as one stark example, I read recently that the nation of South Sudan, with a population of 11 million, has more vice presidents, 5, than working ventilators, 4. And that much of Africa and parts of Asia in particular, healthcare workers simply don't have the equipment they need, whether it's the personal protective equipment, the ventilators, the oxygen supplies, to treat any potential outbreak that might occur in their populations. So I guess my question to you is, in these particular cases, what are nations to do? What strategies can they put in place to prevent health catastrophes?
So I don't believe that you build system in the middle of solving a health catastrophe. And that's why after Ebola, I was so disappointed, because it was clear that for Nigeria, Senegal, Guinea, Sierra Leone, Liberia, who have faced who have faced the epidemic, it was clear all the African countries came together and say, we need to build health system. However, it was refused. The big institution came together and say we cannot invest in that. Today, we can see exactly the same. Even though the preparedness is multisectorial and out of the system. What I want to say for Sudan is that we need to react now. We need to save the maximum of people now. However, if they don't build a system just after the recovery of COVID, we are going to have another pandemic, and this is sure. And they will face the same situation.
Mm-hmm. Great, thank you. Let me circle back now, Dr. Punjabi. I want to touch back on what you had talked about earlier, which is the fact that at the end of the COVID-19 pandemic, we're very likely going to be in a situation where many more people will die of hunger or diseases unrelated to COVID-19 than from COVID-19 itself. In fact, I was just reading the chief economist at the World Food Program estimated last week that an estimated 265 million people could be pushed to the brink of starvation by year's end, which was double the numbers that they had initially thought were facing acute food shortages. Can you talk to us a little bit more about the sort of ripple effect and the fact that in many of these low-income, middle-income countries, all other access to regular health services, vaccination programs, even just getting food safely to people who need it has been interrupted by all the activity around the pandemic?
Sure, thanks, Derek. And some of this will echo what my colleague, Dr. Agnes, just spoke about. You know, in a pandemic, there is naturally a focus on those hotspots. You cannot suppress a virus without getting great testing and tracing and isolation and treatment. You just can't. When we focus on those, we can neglect the rest of the health system. How does this play out? I'll give you an example. Just last week, some of the communities that Martia, I mentioned earlier, and her midwife colleagues are serving in rural Liberia had managed to get the proportion of mothers delivering in facilities up by over 50% in the years up to the COVID. But when COVID hit, there was a fear amongst the community that they would contract COVID from going to the health center to deliver a baby. And in fact, a 21-year-old mother, expectant mother, was too afraid to go, and she fell into obstructed labor, meaning she had a complicated labor and couldn't deliver her baby in her village, and perished, died in that village because not of a lack of a facility, not because of a lack of a midwife, not because of a lack of the equipment, but because of this contagion that goes beyond the initial epidemic. So, I think the lessons we've learned are that the best emergency systems are not emergency systems per se. They're everyday healthcare systems that can be surged in a crisis. If that clinic, if that community health worker had been given the PPE, the right protective equipment, if infection prevention and control was put in and the community felt confident in that infection prevention and control, that 21-year-old wouldn't have lost her life. She would have been right now with her baby in her home, helping grow that child. One of the areas of accountability we all share around this is to not pit prevention and control against care, or to not pit epidemic health security against health systems. These are integrated things for that mother in that village. It doesn't matter what we call it. What she wants is care for her daughter and for herself. And she also doesn't want to get infected, which is what all of us want. So if we want a serious global health security agenda, after this. And I have no doubt, I mean, if this doesn't wake the world up, I don't know what will. I think, if I'm not mistaken, Tim and Patricio, the National Academies of Science and Medicine in the United States, put out a statement. I know, Ariel, I believe you were involved in this as well, a few years ago, after the Ebola epidemic, that said, if we do not increase investment in global health security from about 50 cents per capita to 65 cents per capita, which is about a few billions of dollars, which is really peanuts for the world to do, we could see a pandemic that could cause a $6 trillion economic loss to the world. And that's almost exactly what's happened in this moment. So I have no doubt that the motivation will be there during and after this to get a much more robust global health security agenda. What I am worried about, as my colleague Dr. Agnes said, is when those ministers of health come and say, we want investments in paying community health workers and nurses and equipped clinics and health systems and ventilators and oxygen supply, that those who are concerned about health security may not expand their frame and forget that the best emergency systems are in fact everyday systems. We have to unite prevention and care, not pit them against each other, is my point.
Mm-hmm. Thank you very much. Dr. Liu, I just want to maybe turn to you to maybe build on that. I know you were quite vocal a few years ago around the Ebola crisis and rallying the world's attention around that. Taking off from what Dr. Panjabi just said, do you feel that this COVID-19 pandemic might actually be that wake-up call that the world needs to really stop and rethink how it delivers global health around the world? Are you optimistic at all?
I know I was warned, and you warned us to be optimistic. So, and I'm not one of those characters, but I think that I think we are awake. The issue is, are we going to stay awake? That's the thing. And in addition of staying awake, are we going to have a sustained attention? Because we, like many of generation of kids right now, we suffer from attention deficit when there's an issue. So that is my biggest concern. And unless there is some real, I would say, incentive for people to fix that, it's going to be difficult. And there's I'm semi I would say hopeful because I think that it's quite interesting to see that our international platform that of governance have been very late to react. I find it quite interesting that G20 only woke up here a few weeks ago. I find it only interesting that the UN Security Council, which just been talking about COVID-19 in a serious way at their meeting over the last few days. And why did it take so long when it's really spreading across the globe? Whereas it was less long back then in 2014. It was presented at the UNG in September, the beginning of September, and at mid-September there was a resolution on Ebola at the UNSC. So I think that unless as well ownership is taken because this is what we have, as good as it is or as bad as it is, those governance platforms own the issue, make it a political thing that needs to be tackled in a priority, it's unlikely that we're going to do much better.
Mm-hmm. Thank you. Dr. Pablo Marquez, let me sort of build on that point, if I may. Sorry, I'm getting mixed up here. Sorry, Dr. Pablo, and then we'll go to you, Professor Marquez. I know you talked about international aid earlier, so maybe I'll just put the question very simply to you. I mean, we're seeing right now many of the Western countries that are obviously supporters and sponsors of international aid are simply spending all of the money that they have now and all of their energies to handle the pandemics in their local populations. And they're in fact spending lots of money they don't actually have to sort of manage this. So do you feel that when we emerge from this, or as we sort of continue through this pandemic, there will be any appetite or any financial support left at all for these countries to continue to support international aid programs? And what might the consequences be of a world with much less international aid to go around?
Well, the international aid has not decreased. We just got the report of close to 40 billion a year in development assistance for health. So it's a good thing. But I explained before, the world had changed, not out of money, out of other many good things. I think that so the world is changing already. I believe, just like we used to be called tropical medicine in the first half of last century, and with the end of European colonialism after World War II, we became international health. It was a different game, with countries asserting their independence and voting rights in the UN and primary care and so on. Then with the collapse of the Soviet Union, the pendulum switched away from into AIDS, TB, malaria-driven programs that were successful in so many ways with donors and the World Bank and so on. And that period of global health is ending. I think it's ended last decade with the financial markets collapse. A blind faith in markets is not assurance for people to keep their home, their jobs, their pensions. And so we are entering a new era where there will be political demand for greater social protection by governments. And that era is already here. This pandemic will make that even more clear. In that transition, the noise of history is being seen by populism that offer crazy solutions that do not solve situations, the challenges. And so we are seeing nonetheless a period of populism, protectionism, nationalism, a bad time, because we all know, and again, that response is making it more clear, that we need solidarity, as Dr. Lu pointed out. The virus knows no borders, and so efforts that would allow us to do that, we are not safe anywhere as long as there's the virus anywhere else. And in fact, I was talking about a crazy idea with my friends that all these lockdowns, you're going to lockdown and it's lost things, but then you have to reopen the lockdown. There's controversies as to how to do it, and all of those things are so challenging. I said, if we had true solidarity, we just do one single lockdown in the whole world for a month and the virus dies. But of course, we cannot get there. In fact, I would say that more than money, leadership and community engagement is the most important thing. And a friend of mine was telling me that out of all the simulations they have done for pandemics, all the kind of virus, and even more aggressive than this, and the response, the one factor they never consider is lousy leadership. And that has really not helped us in the United States and in many other places. And so I think that we need to in a way, it demands for more creativity and engagement, but also demands for better leadership in the future. And I think that that's a very important thing. I think we need to learn from each other too. We all went into lockdown consensus and without data, and that's been a mistake. We haven't been able to open our minds to other options. And the British tried and they couldn't. The Swedish are trying. Yeah, they will pay a price, but we can all learn that the Swedish, knowing that 95% of deaths are occurring in people over 65 or with comorbidities, isolate those, but don't kill the economy, because then you will have hunger. My grandmother used to say in Mexico that the 1918 pandemic she lived through, hunger killed more people than the virus. And I think we may end up with economic shocks here, as we saw after the collapse of the Soviet Union and after the collapse of the markets here in the United States, decreasing life expectancy, reflecting millions and millions of deaths, which this virus will not reach nonetheless there. So very important for us to keep our mind open, to keep a balance. We all know that the economy is a very important social determinant of health. Well, if we care for health, we need to keep a balance between the public health interventions, the community and primary care interventions, as Raj pointed out, but also about making sure that we don't kill the economy, especially since we cannot do so for a year or two until a vaccine arrives. And so I think keeping our minds open, keeping a balance is important. And again, the strength and importance of leadership.
Great, thank you for that. And I'm glad you mentioned the economy, because I do want to turn to Mr. Marquez now to maybe ask you specifically a little bit about that. So obviously what we're seeing in Canada and the United States and elsewhere, it's quite of a unique moment. I don't think I've ever seen in my lifetime a situation where governments are actually paying people to not work, to stay home. And we're obviously very fortunate having strong safety nets in, at least in the North American countries and in Western Europe, where people can afford to do that. And governments can afford to support that. But maybe you can talk to us a little bit about what's happening in some of these countries where they don't have strong social safety nets, and people are essentially forced to either go to work and not follow public health guidelines, or starve. And are we seeing situations where the pandemic could get out of control because people simply cannot afford to stay home in quarantine?
Well, thanks, Derek, for the question. First of all, before I answer your question, I would like to go back to my exchange with Agnes. I think it's important to keep in mind. Yes, it's critical to have the Africa CDC. It's critical to have the sub-regional centers supported, let's say, by Radice. But I fully agree with you. The front lines of action are the countries, are the communities. And in that sense, besides the support that we are providing to the Africa CDC, to the sub-regional centers supported under Radice, we are, out of the 57 countries, we are supporting more than 20 countries across Africa, including Rwanda. And the support that's being provided in these countries are not only in terms of case detection, confirmation, contact tracing, recording, reporting, the application of social distancing measures, but also to strengthen the health system or to beef up the capacity of health systems to respond not only to COVID-19 infected populations, but people who need other types of services to address their needs. And one thing that I would like to point out based on the previous comments, yes, the attention should be focused in contain and mitigate the current pandemic. But then again, we have to use this opportunity to start building the necessary interface between environment, agriculture, and public health in order to operationalize once and for all the One Health agenda. If we don't prevent, by the time that the virus reaches communities, we have community spread, is going to be too late. So perhaps this is one of the key lessons that are starting to emerge. So in terms of the incentives that need to be in place in order to make countries accountable for lack of attention to investments in public health and essential medical care, I think that there are some instruments, and I think ministers of finance will pay attention if, as part of the risk rating for countries that guide investments and loans to countries, you include a clause that says, unless the country has a strong, robust, well-funded public health infrastructures and essential medical services, the risk rating of that country will fall down. Therefore, they will have to pay a higher interest rate or a higher premium in order to obtain needed financial capital. That's the only way that ministries of finance are going to realize that the international community, the international finance markets, are concerned about this type of crisis that have a tremendous human, social, and economic cost. And getting into your question, Derek, I think that, yes, at this moment, we have to be very clear that based on initial estimates that were published as part of the World Economic Outlook a couple of weeks ago during the virtual meetings, spring meetings of the World Bank and the IMF, it's clear that that among those countries that have where the population lives below $1.90 per year, an additional 48 million people will fall below that line, so they will fall into extreme poverty. The same thing among lower middle income countries. I think the estimates show that an additional 100 million people will fall within the $3 poverty line. So they are going to get into below the poverty line. So the question is what to do, especially taking into account that remittances, the flow of remittances has been heavily affected. According to recent estimates, The remittances are dropping by 20–30%, and remittances in some countries represent a major source of I will say, of financial protection for families, particularly to get food. So I think that in this case, yes, it's important to look at the public health mitigation measures, but also to inject conditional transfers. In most of the countries of the world, you have now social assistance mechanisms, you have a cash transfer mechanism. So you need to start pumping out those resources in order to help alleviate the needs of people who have lost a job, for example. But at the same time, you need to reactivate with care the economies, given particular importance if you are going to support an enterprise to condition that support to maintaining jobs. Because in some cases, as we have seen here in the United States, yeah, the stimulus money is going to enterprises, but the enterprises are not required to protect jobs. So who is benefiting from that? So we need to be very careful. And finally, the final point that I would like to make is that the economic impacts are not the result of public health measures. That's a wrong conclusion. The economic impact is due to a virus that has spread across the community. Therefore, these social distancing measures that have been adopted are necessary in order to respond to a threat of a virus that has spread unchecked in the community. And unless those measures are adopted, are implemented with the support of the population, with the adherence of the population, the economic price is going to be much greater. So let's be careful about not confusing the effects of public health measures to the effects of the viruses. That's wrong.
Great. Well, thank you. I'm glad I directed that question to you. You certainly have a lot of passionate thoughts on that, so I appreciate that. We only have a couple more minutes left. And I got so many more questions. I obviously am not going to have time to get to today. But Dr. Evans, if you thought that I was going to leave you off the hook today, you were wrong. Maybe I'll throw one more question out at you. I know you obviously are very involved now in the serology testing and peripherally as well in some of the work around trying to get a vaccine. And I guess my question is, from a global health perspective, when the world finally does develop a safe and effective vaccine, do you have any concerns about how this vaccine will be distributed across the world in an equal fashion, in a cost-efficient fashion? Or are we potentially looking at a situation where the higher income countries, such as ours here in Canada and the US, those citizens might get access to this well before those in other countries on the planet?
Yeah, thanks, Derek. And again, thanks to our panelists for a great, stimulating conversation. First, we don't have a vaccine, and I think we need to really look at how we can engineer one more quickly. And as I've mentioned before on this webcast, in response to, in the aftermath of previous epidemics, like the Ebola crisis in West Africa, the world came together and created something called the Coalition for Epidemic Preparedness and Innovation. And that institution started working on coronavirus vaccines in 2017. So I think that collaboration is extremely important, but we probably have to ramp that up significantly if we're going to accelerate the timeline on generating a viable vaccine. Anybody who's been involved in the vaccine business knows that it's very tough to find something that works, and the road to success is typically characterized by many failures. However, I know there's meetings being planned in the near future in WHO to really see how we could ramp up vaccine development in a way that perhaps the world has never seen before, and I think that's very exciting. However, the point that you're raising, which is who gets the vaccine, has to be in the design of the development plans now. Because we have seen, as you mentioned, that when we do have breakthrough technologies, we don't have the manufacturing capacity to get it to all the populations that need it at the same time. And too often, it's purchasing power or privilege that determine access. And I think in this case, we can't afford that inequality. If we really are interested in putting an end to this epidemic, and we do have something like a vaccine, which we think is a viable solution, then we have to muster the ingenuity to get it to everyone who needs it in a timely way and make sure that that access is not limited based on any social structural issues like ability to pay, sex, race, ethnicity, or place of residence. We really have to have a universal access to something like that. And it takes me back to the point I made earlier. We really have to rethink universal coverage in our new interdependent world so that these inequalities don't become the threats to our collective health globally.
Great. Well, thank you very much for that update, and let's hope that the world pays attention to that and can get the vaccine out to as many people. Oh, sorry, Mr. Marquez, you want to jump in? We only have a couple of minutes, but if you can keep it short.
Yes, I'm going to keep it short, but this I cannot escape since we have this forum. Different studies have shown the differential mortality among men and women, and the key cause is associated with smoking. So perhaps one of the to-do lists. To-do list elements going forward is really to ramp up taxation on cigarettes, on e-cigarettes, in order to really make those products unaffordable, mainly because, as we have seen, they increase the severity and increase the risk of fatalities among people who have lower respiratory capacity. Thanks.
So in other words, tax them to death before the virus kills them is another way to put it. Anyway, well, listen, I can't believe how quickly 90 minutes just flew by, but that does wrap up the time we do have today for the panel. Before we close, I'd like to remind everyone that this video will be available at this very same link soon after our recording ends. So feel free to share it with others who may not have been able to tune in live. And please keep watching your email and social media feeds for more information about how McGill is confronting the challenges of COVID-19 and keeping you informed with insight from our academic and medical experts. If you are a McGill graduate who is not currently receiving our emails but would like to be added to our distribution list, you can visit alumni.mcgill.ca/register to sign up, and this link will be available beneath the video player on our YouTube channel. I would also like to remind you about an exciting new funding opportunity that McGill launched last week. That is the McGill Emergency COVID-19 Research Fund, which is seeking to raise much needed dollars in support of the important work taking place at McGill and at the MUHC to fight COVID-19. So if you'd like more information about that fund or you'd like to support it, you can get that information at giving.mcgill.ca. That's giving.mcgill.ca. And finally, I would like to join Dr. Evans in thanking all of our panelists for joining us from all over the world and providing such incredible insight today. Dr. Agnes Binagwaho, Dr. Ariel Pablos Mendez, Mr. Patricio Marquez, Dr. Raj Punjabi, and Dr. Joanne Liu. And of course, again, a big thank you to McGill's own Dr. Tim Evans for not only participating and co-leading this conversation, but for assembling such an incredible array of talent for us today. And finally, a big thank you to our McGill alumni who continue to tune in week by week. And please be sure to join us again next Thursday as we look at how this pandemic has shaken up and is breaking down silos in the scientific community. Among our guests will be the McGill professor who earlier this month was asked to set up a province-wide COVID-19 biobank, as well as a law professor and a member of the Neuro, who are both strong advocates for the philosophy of open science and better scientific collaboration. In the meantime, stay safe, be well, and see you next week. Thank you.
Thank you.